Erythropoiesis is the production of red blood cells. Your textbook has a review of the normal process, but I'll give you a summary here. Red blood cells develop from stem cells into erythroblasts. As you can see from the graphic, these red blood cell precursors move through a series of stages in the bone marrow. Hemoglobin formation also occurs during this time. The reticulocytes are released into circulation and further develop into mature red blood cells. The red blood cells circulate for 120 days. Because they have no nuclei, red blood cells cannot make new membrane components. The red blood cell membranes become weak and they break apart as they squeeze through the capillaries. The red blood cells are destroyed in the spleen, liver, bone marrow, and lymph nodes by the white blood cells. During this process, the iron from the heme units is recycled and the remaining heme portion of the hemoglobin is converted into bilirubin. This unconjugated bilirubin is toxic, and excessive amounts in the blood can lead to jaundice. Usually, the unconjugated bilirubin combines with glucuramide, an amino acid, to make a water-soluble form of bilirubin, known as conjugated bilirubin, which can be excreted in the bile. So what stimulates the process of erythropoiesis? When there is a decreased oxygen supply to the tissues, the kidneys secrete a hormone called erythropoietin. This tells the bone marrow to increase the production of red blood cells. Just a reminder about hemoglobin, it's composed of 2 alpha chains and 2 beta chains. Each protein chain holds 1 iron-containing heme group. Oxygen binds to the heme groups. We'll talk about hemoglobin synthesis during iron deficiency anemia. Anemia is a common problem in the elderly, particularly iron deficiency anemia. This is the result of the normal aging process, chronic illnesses, and inadequate iron nutrition. So let's look at the normal aging process. As individuals grow older, research is showing that the hemoglobin levels also decrease, but not to the levels that will be dangerous. But if they decline in combination with other factors, the lower hemoglobin levels can become an issue. There is some research that indicates the lower levels of hemoglobin then there's a risk of falls. This makes sense if you think about the signs and symptoms of iron deficiency anemia. In addition to hemoglobin levels slightly dropping, the production of red blood cells may also decrease. Again, it is not usually an issue unless the older adult's body system is stressed, such as excessive blood loss, and the body cannot keep up with replacing the red blood cells. Chronic illnesses can also be an issue as far as red blood cell changes. Most older adults have chronic illnesses that predispose them to issues of anemia. The anemia occurs as a direct result of the illness. For example, if an individual has cancer, they may experience anorexia or bleeding. The anorexia can lead to a decreased food intake, which could lead to certain types of anemia, such as iron deficiency anemia. Inadequate nutrition is also an issue. Inadequate nutrition may result from a number of issues, including mobility issues, that the individual older adult may not be able to easily prepare meals and get food to the table. Some older adults have physical limitations that makes it difficult to eat, such as arthritis, or it's difficult to eat meals due to mobility issues. And some individuals may not be able to get to the store frequently enough to get food. And another issue for inadequate nutrition may be financial issues. The older adult may not have the money to buy foods rich in iron. There are also some physiological issues that may result in red cell changes and intake. Some older adults may have difficulty swallowing or chewing. As I said at the beginning, anemias can be categorized by their pathological origin. They can be either a result of impaired red blood cell production, loss of red blood cells, or increased destruction of red blood cells. We're going to start out by looking at the issue of impaired red blood cell production. Regardless of their pathological origin, however, anemia presents with some common signs and symptoms. Because there is a decreased number of red blood cells, there is less hemoglobin available to carry oxygen to the tissues. The cellular response is one in which there is less cellular metabolism and less energy that is produced by the cells. Tissue hypoxia occurs, and the individual complains of fatigue or tiredness, and dyspnea, which is an increased effort to breathe. The body tries to compensate for this reduction in tissue oxygenation. The heart rate increases in an effort to circulate the blood more frequently, so there's an increased cardiac output, and better oxygenation of tissues, and there is also peripheral vasoconstriction. This causes pallor of the skin and the mucous membranes, as well as the nail beds. Stomatitis, ulcerations of the mouth, may also be present, and hypoxia in the brain can cause headaches and dizziness. As with many other diseases, if anemia develops gradually, the body can compensate for the decreased tissue oxygenation. This individual will generally not show any signs or symptoms until the hemoglobin levels fall to 8 grams or below. However, if the individual is experiencing anemia due to an acute blood loss, the signs and symptoms will be more severe and will develop more quickly. Let's go a little bit deeper and review the normal iron cycle. When an individual eats foods high in iron, the iron is absorbed primarily in the duodenum and the proximal jejunum. It is transported in the plasma by the protein transferrin. A majority of the transferrin takes the iron to the red blood cells, where the complex is allowed through the receptor of a red blood cell. Once inside the cell, the iron is released and used to synthesize heme. Notice in the graphic that about 20% of the iron transferrin complex is taken to other tissues, such as the liver, and stored as ferritin. Ferritin can later be released back into the plasma for future hemoglobin production. The most common cause of iron deficiency anemia is chronic blood loss. Chronic blood loss usually means the individual is losing a small amount of blood, but it also means that there is less iron that is recycled to make hemoglobin. Excessive menstrual blood flow is the most common reason for blood loss in women. Gastrointestinal bleeding due to a bleeding ulcer, hemorrhoids, or ulcerative colitis is also another cause for chronic blood loss. Dietary intake of iron is another reason for iron deficiency anemia. In the United States, most individuals receive enough iron in their diet. There are some individuals that are at risk. These include toddlers, adolescents, particularly when they're growing, and pregnant women. Malabsorption can also be a cause of iron deficiency anemia. Any gastrointestinal disease that interferes with the absorption process of nutrients can lead to a decreased iron absorption. So who's at risk for developing iron deficiency anemia? Women of childbearing age are at greatest risk as compared to men. 4 to 8% of premenopausal women do have this type of anemia. Growing children are also at risk, especially during periods of rapid growth. There does not appear to be any correlation of iron deficiency anemia with any specific racial or ethnic group. And mild iron deficiency anemia does not cause death itself. However, moderate to severe iron deficiency anemia can lead to cardiac and respiratory problems, especially in chronically ill individuals, which then may contribute to serious illness or death. We have discussed the signs and symptoms of anemia at the beginning just a few slides ago, but I've listed them here just as a reminder of the more common signs and symptoms of iron deficiency anemia. So how does the physician determine if an individual has iron deficiency anemia? In addition to looking at doing a physical exam and asking about signs and symptoms, laboratory testing will be done, and they'll look at hemoglobin, hematocrit, iron stores, serum iron, and ferritin. In all, the, in all these different blood tests, all these levels will be decreased. A microscopic exam will be done, and the blood cells will be microcytic or small and hypochromatic and have less color. The treatment of iron deficiency anemia is focused on either identifying and treating the underlying cause, increasing the diet with iron-rich foods, or providing supplemental iron. If the anemia is due to chronic blood loss, the focus will be on treating the underlying cause. In addition, the treatment will focus on increasing the diet in foods rich in iron. These would include red meats, egg yolks, green leafy vegetables, raisins, and kidney beans. The recommended daily requirement for iron for men over the age of 19 is 8 milligrams a day. For women between the ages of 19 and 50 years of age, the recommended daily allowance is 18 milligrams a day. Then it decreases to 8 milligrams a day when women go into menopause. You can look up tables for children and adolescents to see their specific needs. You may have noticed in your book that the body uses only 0.5 to 1.5 milligrams per day. For some individuals, especially women of childbearing years, supplemental iron is necessary. These oral supplements, such as ferrous sulfate, are taken to treat mild anemia. These supplements are taken until the hemoglobin levels return to normal, which can take several weeks to months. Individuals should be instructed to take ferrous sulfate on an empty stomach with a full glass of water. If it causes gastric upset, it can be taken with foods, excluding cereals and milk. It can cause constipation, so the individual should be encouraged to eat a diet high in fiber and drink plenty of water. Ferrous sulfate can also cause stools to look black due to excreted unabsorbed iron. Iron deficiency anemia can be prevented. One of the key ways is to look at the diet of the individual and to include foods high in iron in their diet. Also, identifying individuals that may be at risk for iron deficiency anemia and looking at their diet, and also looking at whether it's important to include a supplement as well. As you saw in iron deficiency anemia, the red blood cells are small. Megaloblastic anemias are just the opposite. They are very large, immature red blood cells. The two most common types of megaloblastic anemias are folic acid deficiency and vitamin B12 deficiency. In this course, we will look only at folate deficiency. Let's review what folic acid has to do with red blood cell production. Folic acid is needed for DNA synthesis, which is necessary for the production of red blood cells. One of the vitamin B12's functions is to activate the enzymes that help folic acid move into the cell so the DNA synthesis can occur. If there is not enough folic acid, there's not enough to help with DNA synthesis, which is necessary for red blood cell maturation. If there's a deficiency of vitamin B12, then not enough folic acid can get into the cell and assist with the DNA synthesis process. So the erythroid precursor cells undergo reproduction without the normal DNA, and the end result is a red blood cell that is increased in size.